Kia ora, my name's Margie Olds, and this is the Glenohumeral Gurus podcast. This is a podcast for clinicians interested in shoulder rehabilitation. I'm a shoulder therapist based in Auckland, New Zealand, and in this podcast I interview clinicians and researchers across the globe about their research and their clinical practice on how we can improve outcomes for people with shoulder pathologies. The aim is to learn, laugh, and try to work out how we can help people with shoulder problems. Enjoy the podcast. This episode is brought to you by Flawless Motion, shoulder braces that are designed for people with shoulder instability in male, female, and bilateral versions. So check out flawlessmotion.com for your shoulder brace requirements. We've also just expanded now to the UK, so if you live in the UK or Europe, you can get your shoulder braces much more quickly. So check us out at flawlessmotion.co.uk and you can check out our shoulder braces there. Cheers. Hey, welcome back to part 2 of this session with Michel Martens. So when we learned all about frozen shoulder, and so in this first section we talked a lot about the risk factors in the development of frozen shoulder and making a diagnosis, and in this part I wanted to talk particularly around the role of exercise in frozen shoulder. And I think this is what piqued my interest, Michelle. I saw a post that you had made on LinkedIn, I think, and I was like, oh, I want to talk to that guy and find out more about that. In this session I'm also accompanied by my co-host, Dr. Angela Cadogan. So great to have you with us too, Ange. So I'd encourage people to go back and listen to the first podcast. We're now going to roll into more questions that we have for Michelle on frozen shoulder. So welcome back, everybody.
Thank you.
Tell us then about this role of exercise in frozen shoulder and how that all came about this was part of your PhD, this.
Yes, it was part of my PhD. So we did a systematic review and a meta-analysis on the effects of exercise therapy in patients with frozen shoulder.
Mhm.
And I need to say that I'm a little bit biased because I'm quite into exercise in general, because exercise is always quite easy to advise to patients. Just do it at home when you want. You can come to practice, of course, but then you are more restricted to the time that we are available, that you are available. So exercise you can do at any time that you want. You do not have much equipment. If you need a dumbbell, you can also grab a bottle of water, fill it, and then you already have some weight. So that is something that is for me quite easy and quite simple to advise always to patients. So that may also make me a little bit biased towards exercise therapy. But of course, I cannot use that bias into that systematic review. But luckily, the results of the systematic review were also advising towards exercise therapy. So what we have found was that exercise therapy, independent of how it was applied, it was always useful and beneficial for improving either range of motion, pain, disabilities. So it is beneficial. Um, in general, it can be just solely exercises that are recommended, but mostly the exercises were combined with other physical therapy modalities, manual therapy, shockwave, or that kind of stuff. It was also included. And in all the interventions in which exercise therapy was applied, we found the improvement. Even when we compared no exercise to a program including exercise, there was no difference between the programs. So in the end, we could also ask, what is the benefit of the other modalities? Do we really need the other modalities or not? And the exercise therapy was also applied in a group, supervised or unsupervised. And then
Mm.
we saw a small difference that supervised group therapy was a little bit more beneficial compared to unsupervised therapy. But that was only in one study that compared the supervised versus the unsupervised.
Yeah. I love it when you talk to people who have done these systematic reviews and meta-analysis because they're across, you understand all the literature in that space, don't you? And there's such a number of studies in there. When you talk
Yeah,
about exercise, you talking, I typically think about stretching, but you've also then talked about strengthening exercises as well as some other type. What's the definition of exercise in your, how did you define that?
actually everything in which you move
Mm,
yourself. So it's always active. Um, and that may be the only disadvantage of the study is that there is so much heterogeneity in exercise, in
mm.
outcome measures, and also in the population.
Yes.
So, of course, yes, it was frozen shoulder, and that's the only homogeneity that we have found because
Yeah.
the duration of symptoms, the phases, there was sometimes unclear, and otherwise it was really, really variable.
That was
Mm.
one question I was just going to ask Michelle around that was, um, I guess in the context of a systematic review, there could be a wide range here, but what phase of the frozen shoulder were they applying exercise in, or was that clear in the systematic review? So were they doing this exercise in the early painful phase, or was it only in the later stiff phase? Was that clear through the studies you looked at?
It was, if I remember correctly, mostly in the first two phases, and not so many in the late phases. Um, so mainly the freezing and the frozen phase in which the exercises were applied. Um, and the programs were in general quite short until 6 weeks, with a short follow-up time. I think there was maybe one study or two that had a follow-up time of 1 year, and the others were all already very small within a few months. So there is also some room to improve to say, well, we need a longer follow-up of the results of the exercise therapy.
Mm.
That would be interesting to know, I think.
Did
So,
they
yeah, sorry, go, Ange.
Oh, that's right. I was going to ask, did they tend to apply, say, a universal sort of exercise program regardless of stage? I suppose probably what I'm interested in is, was it a pragmatic kind of exercise program in many cases where during the painful phase they were just doing, limited range of motion, not pushing to the end range of motion, mostly passive, that kind of thing, versus when the pain levels were lower, then they got into more high intensity stretching and exercise. Did they structure their programs that way, or was it more just looking at here's a range
Uh,
of exercises regardless of stage?
it was rather the last. So there was no differentiation between high irritability or pain phase or whatever. So it was a standardized program, at least as I see it, that was applied to all the patients. And um, I think that is one of the important limitations as well. And not only in this study or in studies, but more and more in many studies nowadays, because yeah, we see so many underlying variables, predictors that have an influence on several factors. We need more patient-centered care to
Mm.
see what is really effective. Um, we cannot apply all standardized exercises or treatments to all patients with a certain disorder. Um, of course, in the beginning, it's very useful to see what does it for the full group, for the complete group. But and especially in frozen shoulder, we see that there are many more subgroups arising
Mm.
nowadays. So and I think that is important to acknowledge that we should focus more on person-centered care and stratifying care. and that we should try to apply that in our research as well. And when we can apply that in our research, I think we can make huge progress towards the clinical settings.
It it makes me wonder because I think when you think about the exercises here, the pathology for frozen shoulder, as we talked about in the first podcast, is intra-articular. And so I wonder the clinical rationale for exercise. My current practice, just to divulge what I'm currently doing, if you present now, a patient presents to me in early stage frozen shoulder, I'll refer for intra-articular steroid injection because I am looking to change the intra-articular synovitis. And then when that has settled, then I will prescribe end stage stretches at a level that is tolerable discomfort, I say. And I haven't particularly focused on strengthening exercises. I guess what I'm interested in and why I reached out, should I change my practice? Should I be doing something different? What do you think?
What do I think? If we take a look from a sports perspective, in general, we say we start with strengthening exercises when full range of motion is available. Because then you can do the strengthening exercises in the full range, which makes more sense than doing strengthening exercises in a small range. But on the other hand, if the strength is decreased so much in the early phase that it's hard to do some activities, I can imagine that you will do some strengthening exercises. So should you change your practice? I think it's more important to focus on the patient. What is important for the patient? Is the patient really missing already muscle strength that affects doing activities? I think you can clearly do some muscle strengthening exercises. And otherwise, just do some range of motion exercises. I don't know if there is a clear rationale to say you should do exercises because of something specific. As I already mentioned in the previous version, exercises are quite helpful for many things. So we also have mental health. So just start walking if you cannot do specific exercises, but also with specific exercises, if you are moving and you can already slightly increase your heart rate, it has beneficial effects for the whole body. So I think that is also one of the elements that we may consider. Just do some exercises, feel well, feel better, and then
Yes.
when you start feeling better, everything will go much more smoother.
Mm, mm. Is that your current practice, Ange? You're doing different than me? I mean, I'm sure it's
Mm.
way more sophisticated, but
No. Very similar. So painful phase, usually intra-articular glenohumeral joint corticosteroid injection.
Mhm.
And probably on that topic as well, from personal experience, is the earlier the better for that glenohumeral joint injection. I've had two, and my second one, my shoulder was already very stiff by the time I came to have that second injection. And even during the procedure, the radiologist couldn't even get, I think it was only 5 or 6 mils into the joint, whereas
Mm,
normally it would be around 10 to 15 at least. So I'm not sure how much actually went in, therefore I didn't get a great response from that injection. So I think the injection early on is certainly what I've learned from my own experience. But then very similar with the exercise. So I would generally, I find the patients are, especially in that painful phase, they're irritable enough and they're already doing enough during their daily activities that I find if I add anything else to that, it just makes them more painful. So I do tend to wait until that irritability comes down, and then stretching is generally where I go first.
mm,
I haven't focused a lot on strengthening. I generally find once they restore their range of motion and get back into function, they tend to not seem to lack much in terms of functional strength anyway. But again, it's not an area that I've focused on. So yeah, very similar to you, I think, Margie.
And I guess, and that leads us into Michelle around hydrodilatation as well, steroid versus hydrodilatation, whether what the thoughts are in that space. Do you?
Yeah, I'm not really familiar in that topic because in Belgium and in the Netherlands, we are not allowed as a physical
Mm,
therapist to use corticosteroids. So it's only for the orthopedic surgeons who can do that.
right. Yeah.
Um, and there is indeed evidence that a corticosteroid injection in the early phase, before the movement restriction occurs, that is the most useful. And indeed, as Angela said, if there is already the movement restriction, the corticosteroid injection appears to have less benefits. So, besides the personal experience, it is also found in the literature that is that the case. Um, but of course, that brings us again by the difficult topic: is it a frozen shoulder, yes or no, in that early
Yeah.
phase?
Yeah.
Um, but besides that, and hydrodilatation, there is much debate about it, whether it is useful or not. I recently heard that an orthopedic surgeon said that they never did hydrodilatation anymore because they found it not useful.
Mm,
Um, and then, if it is it possible to inject and then with the magnitude to in the end rupture the capsule, is that really the case? So
mm,
there is very much debate about using hydrogelitation,
yeah.
but the exact way and numbers, I'm not really familiar with that.
Yeah. And that leads me into another systematic review that I'm yet to get back to that looked around suprascapular nerve blocks versus steroid injection. What do you know in that space?
Yeah, my first question would be, why would you do suprascapular nerve block in a frozen shoulder? The only thing that I can think of is just for the
Mm,
pain relief.
mm,
And then, okay, then you should do a next step, I think, because with only relieving the pain, you will not resolve the capsular contraction that is present. You will not resolve the inflammation. So you need to do something additional to the
mm.
suprascapular nerve block, in my opinion.
Yeah. Well, makes sense if we think about what the patho anatomy is and what actually happens that needs addressing, you would think.
Yes.
Can we lead then now into the Delphi study that you were part of and what that involved and what clinicians should know about this study? What can you tell us in that space?
Yeah, I think there are many elements in the Delphi study that we actually already discussed in the
Mm,
risk factors, about
hmm.
etiology,
Yes.
about the role of psychosocial factors
Yes.
within the management, within development of the frozen shoulder. Um, so yeah, and regarding the diagnosis, that it's mainly of ruling out in the first instance. That the other factors can confound the diagnosis of the frozen shoulder, like muscle guarding, osteoarthritis, poor clinical reasoning.
Mm,
Um, yeah, and of course the signs and symptoms were also yeah quite quite obvious that we already discussed. And then the management. Let's see that there were very that there is a nice progress from the early phase towards the late phase in what is recommended to do, or what is at least appropriate to do in the early phase, that you are more for pain relief in the early phase and going more to stretching and increasing range of motion in the later phase. So yeah, that's already quite a lot that we
yeah,
discussed.
we've
So I
already
don't know if
covered.
you have any specific questions about the Delphi study.
I am not, I was just I just wanted to make sure that we had covered everything off that you thought was important that clinicians took away from that. So yes, I think as we have been talking through this process, we've covered through that really, hasn't it? And I guess it kind of explains the difference in in New Zealand, physiotherapists are first contact practitioners, and they also then can refer for steroid injection. So it probably what we are doing here in New Zealand might be different than what other clinicians are doing in other healthcare systems because of the way the healthcare system operates too. I guess that's useful to point out.
Yeah, and I think we should always remember that there are huge differences in the world. So in the Netherlands, they are freely available, but they cannot refer a patient to directly to an orthopedic surgeon for a corticosteroid injection. And they first have to go to the general practitioner, and then the
Yeah.
general practitioner can say, okay, you can to an orthopedic surgeon. And on the other hand, in Belgium, patients cannot go immediately to the physical therapy. They recently started with some diagnosis that patients can go there.
Mm.
And that's only two neighboring countries, and there's already a huge
Already.
difference in physical therapy practices. Yeah.
Yeah, so fascinating, isn't it? And I think it's really important for clinicians listening across the globe that they understand how the differences of healthcare systems and what that means for how clinicians operate. Is
Yeah, for sure.
Yeah, it's really interesting. I guess it takes me into when you mentioned osteoarthritis, the one thing I was thinking around is the role of X-ray. I have then read around you should exclude osteoarthritis as a diagnosis and for loss of range of movement. And I know Ange has some thoughts on this. Do you recommend either of you, I guess, about the role of X-ray in diagnosing frozen shoulder? Is a diagnosis of exclusion? They have to be clear X-ray before we should proceed with assuming we haven't really discussed that. What's the role of imaging in a frozen shoulder?
Yeah, regarding X-ray, I would not recommend it to do it routinely because there was also a study done on that, and it does not add any information. It only rises the costs. It takes time from healthcare practitioners. So, in my opinion, X-ray should only be applied when there is any suspicion of osteoarthritis or any other disorder that can be ruled out with X-ray. So, posterior dislocation, for example, might also be something like that.
Mhm.
But then, of course, the X-ray needs to be taken in a special place because apparently, when you take it from the front, you can still not see whether there's a posterior dislocation or not. So that makes it already again quite difficult. Um, but there might be some interesting elements in, for example, ultrasound imaging or maybe CT scan, because the coracohumeral ligament appears to be involved. The recesses appears to be involved, and that are some elements that we can scan with the ultrasound. And those might also be interesting in the early stages. So if we can do research on the early stages and see,
Mm.
all right, we see something on the coracohumeral ligament. Is it maybe a little bit thicker? Is it more stiff? Um, and we can see that the recesses is getting smaller. And those patients are developing into a frozen shoulder. We might have some information for early imaging with ultrasound to say, all right, we see this happening. So we should be very cautious and very alert that this patient may develop a frozen shoulder in
Okay.
a few months.
Yeah. You have any thoughts in that space, Ange? I know you have some thoughts in that space. Share with us your thoughts.
Oh, no, I agree with Michelle. I think in terms of X-ray, I mean, frozen shoulder, for a definitive diagnosis of frozen shoulder, it isn't a diagnosis of exclusion, so you really technically do need an X-ray to fully exclude any other cause of joint stiffness. But the practicalities of that in the clinical sense, I agree with what Michel said, is that there is probably no clinical need to X-ray everybody unless there are concerns, so red flags, trauma, previous history of cancer, possibility of infection, as he mentioned, locked dislocation, proximal humerus fracture, sometimes avascular necrosis as well. So if there's concerns, if they sit well outside the typical age range for a frozen shoulder, so younger than 40 or much older than 60, then yeah, the more red flags I guess you have, the more important it is that you do get an X-ray to exclude those conditions. Um, I think it would be great, exactly what Michelle said too, around those early ultrasound findings. I think that's really promising to help us differentiate which, an early frozen shoulder from other shoulder conditions, which is really, really difficult to do in those early stages. The only other thing I'd say is we're seeing a lot more MRI findings come back now, reporting things like thickened glenohumeral ligaments and other associated findings that reports are saying, maybe frozen shoulder or adhesive capsulitis, which is a bad old term that we don't really use anymore. But I think we just have to remember it is a primarily clinical diagnosis, and those MRI findings may be associated with it, but if the patient doesn't have a corresponding loss of range of motion, then we can't say that they are diagnostic based just on those imaging findings alone. So it really comes back to that clinical examination.
Yeah, that's
Yes, indeed.
yeah, useful advice. In closing, what do you, Michelle, firstly, what do you think is important that clinicians know about frozen shoulder, use in their clinical practice to help their patients? What's the key thing that you want clinicians to take away after listening to this podcast?
Well, that they start with advising just moving within the pain-free range of motion and starting with that advice already in the early stage, not waiting until the pain decreases. You can move within a pain-free range of motion usually, and if you cannot do that, just go walking, go cycling, whatever you want, whatever you
Mm.
like.
Yeah.
Get in movement, and especially when there are the underlying mechanisms like we discussed, like diabetes, hypertension, maybe thyroid disease, dyslipidemia, all that factors. If you see one of them in your patient, advise them just go for a walk, go for a bicycle, do something that you like, maybe some lifestyle changes as well with diet, but that might be the most important elements uh, for that subgroup. And if those are not present, then we can still advise just move with your shoulder within the range of motion, do some exercises. If the patient can do the exercises themselves, let them do the exercise at home. Ask them to come back after 2, 3, 4 weeks, depending on what the patient prefers. And if they say, well, I know when I'm at home, I will not do any exercises, then ask them to come to your clinical practice once, maybe 2 times a week. Do some group exercises with them so they have also some social contact, maybe even with other patients with frozen shoulders, so they can talk to each other. They have understanding from each other. They have understanding from the clinicians. And maybe some other point that I not mentioned yet is that all clinicians should speak the same language, should give the same message. Because when a general practitioner says something different than the orthopedic surgeon and the physical therapist, then the patient becomes insecure. They don't know what to do, they don't know what to follow. So that might also be a very important message, in my opinion, um, to talk with the person that referred the patient or that the patient goes to. Well, I informed the patient in this way. Please also do it like that. And if you don't agree, try to bring it a little bit more nuanced and don't say something completely different, because in that case, it will be really a big problem for the patient and
Yeah.
it will not help the recovery in the end.
Yes, I think that's a really important finding, probably for all shoulder conditions, isn't it? I often ask
Yeah.
patients, what is it that you understand about your condition, just so that I have an awareness of where they've come from. So, yeah, that's really, really great advice. Ange, what have you learnt today? What do you think is important for clinicians to know in this space?
I think probably my key takeaway is that I think with treatment, we're really trying to match our treatment with the pathologic stage because I guess there's
Mm,
things that we can do that may make things worse at certain times and that may be more appropriate and make things better at certain times. So I guess my takeaway would be in that early inflammatory stage is because of that fibroblast differentiation that Michelle mentioned, the more
mm,
you stretch the inflamed, painful shoulder, potentially the more contracted it might become.
yeah.
And then, with all of the abnormal cross-linking and things that you may end up with a stiffer shoulder than you would have ordinarily. But then I guess as the pain settles and it's less inflamed and it just becomes more stiff, that is probably when we have more of a role for our more aggressive end range stretching and mobilization, although with good reason there is doubt as to whether we can actually stretch a contracted capsule because they are very, very stiff. But certainly in terms of stretching and exercise, I think that would be the time, really, the appropriate
Yeah,
time.
I
So
don't
those were probably my
inadvertently
key
make your
takeaways.
patient worse, is what you're, yeah, that's really good advice.
Mm.
Hey, well, thank you both for your time. It's been really wonderful to dig into this and listen to all the great work you've been doing in this space, Michelle. So thanks for making yourself available. I've really appreciated it.
Thank you for your time and for the invitation. It was a very nice chat.
Yeah, thank you. Thanks, Ange.
My pleasure. Thanks, Michelle.
And thanks again to Flawless Motion for supporting this episode. So, if you want to know more about the shoulder braces or other clinician resources, then head to flawlessmotion.com or flawlessmotion.co.uk for more information. Thanks for listening. I hope you enjoyed the podcast and found some clinically useful tips for your patients in clinic. Please subscribe to the podcast and follow me on social media to keep across the latest releases of the podcast. Don't forget, if you need a shoulder brace for your patients, then check out our shoulder braces at flawlessmotion.com. And if you want to know more about assessment and treatment of rehabilitation of your patients, then check out the online shoulder courses at margieolds.com. Otherwise, take care, enjoy, and see you next time. Please remember that this podcast is for educational purposes for clinicians only and does not constitute medical advice. Please consult with a qualified health professional or contact me to book an appointment for individual assessment and treatment. Cheers.